Thank you so much. They put a journalist on the left, which I think, I don't know, we have to be leftist or a rightist here, but at least let's do what is right here. So, first of all, I think an incredible panel. I think it's a dream panel in a sense. We have um a scientist, physicians. We have healthcare hospital management gurus. We have a digital interface services space player, and we have diagnostics. I mean, when we talk of healthcare and healthcare impact in particular, I think this more or less this dais represents in terms of the kind of expertise and in the segments in which we need expertise. It's very well represented. So a huge round of applause for the incredible speakers, and I think they have come from long distance as well. So thank you. So if I can begin with you, ma'am, Dr. Soumya, uh, you've heard, until unless you would have some initial impressions or initial comments to make on what you've heard. Uh, the first question is essentially about you from World Health Organization to India, and looking in terms of how we've been seeing reports of how infectious diseases are again there is a resurgence of it. Resurgence has now become a redundant term, but it's happening. NCDs was mentioned as well there. Some thoughts in terms of, while we look in terms of impact, some thoughts about preparedness when we have challenges like this, which we know will unfold at some stage. Some initial thoughts, apart from if you have any comment to make on what you've heard this far.
So thank you very much. Thank you very much to Effie for having arranged this, and congratulations on that. It's a fifth annual event that you've been hosting. I think we've had two excellent talks this morning that describe the country's commitment towards expanding universal health coverage, which of course includes the public. From the public sector, minister spoke about the Ayushman Bharat program and the strengthening of the primary health care, but also our systems and institutions. And Rajiv Raghuvanshi just gave an outline of how our drug regulatory system is being strengthened. Very, very important, as India, as you know, is known as a pharmacy of the world. But the issue of quality and the issue of innovations, I think, is now recently being taken much more seriously and addressed. So I think that I strongly believe in institutions. If you have strong institutions, then it enables the whole ecosystem actually to function well. So the other institutions that are relevant for us are the FSSAI, which is a food safety and standards institution. It's very important given the current context of the increase in metabolic disease, obesity, diabetes in the country. I think all of you coming from the health sector would know that the burden is increasing so much that at some point it's going to be impossible to catch up. How much tertiary care can you build to meet the needs of growing demands of the burden of metabolic diseases? And not only that, the expenditures that people will incur are incurring. And while Minister rightly pointed out that out of pocket expenditure has come down, it's still around 40%, which is amongst the highest in the world. And why? Because India has a huge demand for healthcare, and the demand is being met, of course, by public, but largely by the private sector as well. And we know that outpatient care, for example, 70% or more of outpatient care is provided by the private sector. And that's not covered by Ayushman Bharat. So the out of pocket expenditure occurs because of expenditure on drugs, diagnostics, and travel, and so on, to actually meet the healthcare providers. And while the insurance is taking care of the inpatient, I think this large thing is still left uncovered. So that's something that we will have to address going forward so that we can reduce the out of pocket expenditure, because we know that it's the poorest who suffer the most because of catastrophic health expenditures. And many people who have come above the poverty line go below the poverty line again because they have to spend suddenly on a health emergency, including things like TB, for which, by the way, the government has a huge program free diagnostics, free treatment, and yet people still go into catastrophic health expenditures because they can't get to the right place at the right time. So, a lot is to do with the distribution of health services and how people can access them. So, I hope that the private sector would also start looking at this seriously to see how do you bring down out of pocket expenditures, especially for people who cannot afford it. And one way is by trying to keep them healthy. And I think the next phase of our health programs and reforms really need to address prevention. You talked about preparedness. Preparedness is not only for infectious diseases. We know that there could be another epidemic, a pandemic, and so on. And yes, we need to prepare. But the major risks today for our health, if you look at the global burden of disease, is dietary risks. So, people consuming unhealthy diet and pollution. Smoking and all has come down in because of the strong programs and so on. So air pollution is like the number two risk factor for health today, unhealthy diets, and then comes alcohol, smoking, high blood pressure, high blood sugar. So the metabolic diseases are going up, 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 and it's projected that cardiovascular disease mortalities, premature mortality due to cardiovascular diseases increasing dramatically. Of course, we are living longer, but if you look at the gap between healthy life expectancy and life expectancy, that's still around 10-year gap, which means that most people are spending about 10 years on average in poor health with multiple comorbidities. So I think it's our responsibility as health professionals to ensure not only increased lifespan, but with a good quality of life. And which means that we've got to. So I think the opportunity here is when you meet people who are at early stage of illness or you're not yet diseased, can we intervene, including using digital technologies for outreach and so on, to put them on a healthier course so that they don't end up requiring dialysis and bypasses and things like that at a young age, which is what is happening today. Preparedness also means looking at the risks that we are going to be facing, and that's climate change is number one. And we see the heat impacts on people already. It's impacting everybody, including health professionals and our output and our productivity. So heat is going to have a massive impact on productivity, on the economy, if we don't look at addressing it. So that's climate change, vector-borne diseases, and other things as well. But also the antimicrobial resistance, which again is something that this community needs to think seriously how to address. And I think one of the ways is really to take very seriously the antibiotic stewardship. We heard again this morning about the new antibiotics, but what Wockhardt has done has been after 20 years of research and after the fact that all big pharma companies withdrew from research on new antibiotics. So we're not going to see too many new of them coming out. So we need to preserve the ones we have. And that's by good infection control committees, policies, and I think transparency with data. I would love to see every private hospital chain put out data on antimicrobial, uh, on AMR resistance patterns in their own hospital, inpatient as well as outpatient nosocomial infections. And what that will do is it will start creating a standard to aspire to. You will see some hospitals are achieving much better. And I've seen this happen. When I was at DG ICMR, we had a big program led by the AIMS Trauma Center. And it was found that very quickly, within a year or two of setting up strong infection control measures, the not only did the rates of nosocomial resistant infections come down, the expenditure by patients came down because naturally, the more antibiotics you use, the more the patient has to spend on care. And so it benefits the patient, it benefits the hospital community, and your outcomes improve. Obviously, you have less mortality related to AMR. There are only a handful of hospitals today that actually put out this data, on their website and make it transparent. In the US, UK, for example, the NHS actually demands that hospitals are transparent with their health outcome data so that patients also know if you want to go for a particular procedure, which hospitals have the best outcomes. And there are certain specialized ones which Obviously, some will do better than others. It's also a question of communicating. Health literacy in our country is still very poor, and so the more that we can do, I know there are a lot of social media influencers now who are putting out health information. They're not always the right kinds of information. So I think as responsible health sector professionals, we could also think about how we make health communication and health literacy part of our responsibilities. So I think government
Yeah.
is doing a lot, which we heard, but other sectors, especially the private sector, needs to step up. The pharmas, of course, on the innovation side, more investing in R&D. But I think on the hospital side, I think there's a lot we can do to improve quality of services, transparency, and reducing the out-of-cost expenditure.
Thanks for actually referring to all of these elements, and certainly I think we did hear that about what the government has been doing as well. One benchmark which I was looking at about a decade earlier, the National Health Policy 2017. And of course, in the prevention aspect, they did talk of introduction of newer vaccines, expanding the portfolio. I think probably I'll come back to that a little later. But an important point which you said about the data which is there now, and the way hospitals are generating data, using data. Mr. Vipul, if I can begin with you on this, actually, we discussed this point earlier about how data is becoming important for hospitals. Uh, how is that being leveraged? How is the data which is being generated leveraged, and uh, not necessarily data which is towards, say, uh, addressing the balance sheet aspect of it, but looking at the health impact, the clinical outcomes. How is what's your take on how the data is being leveraged? If from your own personal experience, maybe you could even add.
Sure, sure. Thank you. And thank you to first and foremost Financial Express for this opportunity. Uh, I will start with heard about access and affordability in the morning a lot, right? I will add the third element, which is very important in healthcare, which is quality, right? Quality healthcare should be the first priority for each and every objective around healthcare, is my belief. If we talk of now the future, uh, we at CK Birla Hospitals, for example, because you asked this specific question and we were discussing this, the first, so every quarter we go back to Mr. Birla and showcase this has been our performance in the last quarter and this has been the performance in our last year. The first slide of that presentation is a clinical indicator dashboard, right? That dashboard includes infection control rates. That dashboard includes return to ICU, return to OT, return to ER. That dashboard includes compliance on medical documentation. It includes unexpected mortality data, right? So somebody got admitted to the hospital, was not expected to die, but still died, right? And this is where I think the tone is set. After that, obviously, we follow with many slides. It talks about patient experience, it talks about our financial performance, so on and so forth. But that is what sets the tone for our organization, right? And this is where I believe the importance. See, sometimes a little sensation will help. So, for example, if you guys have Chat GPT, if you search preventable medical deaths in United States, right? There are multiple studies pre-COVID, not very recent, but pre-COVID. They are as high as 3 to 4 plane crashes every week at the minimum, to about 2 plane crashes every day. Now, just for effect, I'm sensationalizing this because if this was the frequency of fatality, trust me, I would have never traveled on a plane. I would have driven or, found some other medium.
Roads are not safe as well.
Correct. But we don't realize, and that is US, right? The challenge maybe in our country is uh, first not to make it safer, but first to start tracking, is it safe, right? First, if you start tracking and saying this is our quality of care, this is the uh, infection rates, this is the mortality rates, this is the reasons for mortality, this is the quality of outcomes. I think that is the starting point of where we will change the way in which healthcare is provided in this country. And I can come back to more details, but yeah.
Yeah, no, I think the clinical dashboard, infectious disease, particularly that dashboard, and looking in terms of unexpected deaths and all those things are important. Is it making a difference? I mean, have you seen that in the numbers? I mean, and how do you ensure that this is actually practiced? Because it's nice to have a dashboard, but ultimately numbers matter.
So I think
Very briefly.
two or three things make a difference. One is starting to track and giving it importance. So as I said, we give it the right importance in terms of our reviews, etc. Second is incentives, right? So I recall when insurance made NABH accreditation a mandatory pre-requirement for empanelment of a better rates. NABH accreditation requests across the country went tenfold, right? I mean, everybody wanted to be NABH accredited. So incentives do help. And third, I think somewhere law, or I will say rules help, right? So if we define rules and laws around saying we will track outcomes, and it is mandatory to share digital health data. We spoke about the whole ABHA ID and the electronic health exchange, but if it is made transparent, then it can be reviewed, it can be audited, it can be questioned, and accountability can be driven. So these are elements which help.
Yeah, great. I think, yeah. Mr. Surendran, given that you're from the diagnostic space as Metropolis, which has been expanding geographically. I mean, you've been expanding the footprint, getting into smaller towns and districts across the country. This was something which the minister has also touched upon in her address. i- Diagnostics is a unique space where actually you there is digital pathology, there is a lot of AI being used in radiology, but at the end of it all you need the phlebotomist to go and draw blood. And even in metros we don't have necessarily the best of phlebotomists. I mean, if you have a thin vein, I'm sure many will still struggle to draw blood. If you want to use technology, then again there is these scanners which are there for the pathologists can scan that and send. But then these are very expensive, and at the same time also power situation. I mean, there is sometimes if there are disruptions, then how do we do all of that? So how have you cracked this problem in terms of expansion, but at the same time looking into these aspects, a trained phlebotomist, dealing with costly equipment, but at the same time equipping for these challenges? Some thoughts there will help us because we're talking of impact here.
Sure. Thanks, Kumar, and thank you for having me today on this panel. Uh, you're right. I think the healthcare is definitely expanding into beyond the metro towns. Expanding into tier two, tier three towns, and actually beyond, and ensuring that the good quality of resources available there for providing. The patient care is very important. Very important aspect. If I had to give you some numbers. Today, almost 25, 28 percentage of the total healthcare spend is happening beyond tier 2 towns. And that market is actually expanding bigger than the metro market, which is expanding by about 10, 12 percentage, whereas the tier 2, tier 3 and beyond is growing by about 30, 35 percentage. So maybe in the next maybe 5 years or so, the tier 2, tier 3 market is going to be bigger than the metro markets, and also the growth will be bigger. So it's important for the healthcare ecosystem to stay focused on growing and getting the good quality of resources, good quality of diagnostics, good quality of care, etc., happening in these places, right? So, like Kumar mentioned, the challenges, of course, is about getting the good quality of. In our business, is largely about getting a good quality of labo and maybe a good pathologist in that town. But you talked about scanners, etc. But let me tell you, as per our regulation, reporting is still not allowed. So the doctor has to be there in the lab for to check the report and report. So I cannot have a digital image coming here and reporting that in that sense. So I'm regulatorily obliged to have the doctor kept there. So we normally work on a hub and spoke model. For example, Metropolis as a company, we expanded to 750 towns in this country. As of now, we provide services in the top 750 towns of this country. So the way we done this is we expand the centers and we create a lab maybe as a hub, and the center, the patient sample collection centers have been done as a hub and spoke model. That's what we do, and the doctor actually sits in the lab, main lab, where the services, I mean, the samples comes at the end of the day. And also using technology and and innovation, what we do is the regular samples, which is maybe a routine or a sample or not very specialized kind of a diseases, the testing happens in that rural lab. But if there's any specialized diseases need to be tested, the sample comes to the next bigger lab in maybe in the tier 1 towns. That's a model that we use it. So getting talent is always been a challenge. But I think we as a company put a lot of efforts on training. I mean, even in metro towns, when you get a talent, they have to go through, I mean, stringent training, and they have to go through many of the calibration processes, and they have to pass many tests before even appearing in front of a patient, whether to draw the blood or get his sample tested in the lab, etc. So the challenge remains, but the effort is basically to make sure train these people and get the best of the situation. But as we progresses, we are really seeing that as the day progresses, we are really seeing doctors, specialized doctors are moving into tier 2, tier 3 towns. Hospitals are coming, clinics are coming in these big cities. So it's at the end of the day, the entire ecosystem between diagnostics and the hospitals and digital health and all put together makes a good healthcare system in the rural area. So the efforts are on to make things better, but the focus is only getting the right quality of people. Yeah.
So training of this local talent there, and even if you don't use digital, have a hub and spoke model where it may be easier to maybe just send the sample to the district rather than maybe use
Yeah.
digital intervention there.
That's right. So we ensured very stringent quality control systems, So right from whether the center is open, whether talking to the patient properly, everything has been properly monitored. So we have very stringent systems, and when the sample comes into the lab, how they are testing, everything is going through a very stringent internal quality control system.
So then you must be using AI also. They talk of these days ambient listening by
Right.
AI.
Yeah,
So
we have been used for all the non-science areas, at this point of time. But I think all specialized disease-related sample come to the bigger lab where you have the entire doctors and the ecosystem sitting there, and that get tested there, right? Yeah.
Okay. Dr. Santosh, from given that you are also from a charitable institution and as one important area, but of course, apart from the various areas that you looked at, the NCTs was touched upon there, and in oncology, you've been doing some work, and this is becoming increasingly a serious problem in the Indian context. So, when you talk of expansion and going to beyond the metros, uh, how do you therefore ensure that this element of impact is felt and is actually making a difference? Talk us through that if you can.
So thank you, Kumar, and thank you to Financial Express for having me as part of this distinguished panel. Right in the morning, the Honorable Minister as well as Madam both mentioned about access and how do we reach out to tier 2, tier 3 towns. Now, when we started off, it was a large 750 bedded hospital with a strong focus on onco. And over a period of time, we realized that many patients would come for surgery to large cities. But when it comes to radiation or chemo, it was a bit of a struggle because these are long drawn treatments. They would last for 2 to 3 months. And sometimes the cost of treatment would be actually superseded by the cost of staying in these metros. So what we tried and did was to try and take this care into the community. And as a result of this, we identified 18 districts in Maharashtra which did not have a linear accelerator. And we did a pilot by starting with 3 such districts, which were Akola, Gondia, Sholapur. These are all large towns, but no access to a linear accelerator. So patients from there used to come to Mumbai, Pune, or Nagpur. So we set up these centers we invested in high-end technology similar to what we have in Mumbai. So we actually spoke to the vendor and we said, we are looking at this huge chain, and we did a deal for 18 linear accelerators. We started with 3 of them. So we took land in the outskirts of these cities because we knew that still patients would travel because they did not have any access to that facility. These are typically 15, 20,000 square foot facilities which have got one linear accelerator, 15 to 20 chemotherapy beds. We looked for young radiation oncologists. Radiation oncologists are privileged to do both radiation and chemo. So we looked at these people who were trained working in other large metros, but actually having roots over there, who are willing to go there because they would get access to a good facility. So we set up these centers. All the treatment plans using technology are actually reviewed and validated by our center in Mumbai. So using technology, we are able to validate all the plans. And before the treatment is delivered, our senior radiation oncologists in Mumbai take a look at all these plans. The response to this has been exceptional, I would say, because each of these 3 centers today, the radiation oncology machine is full. We are treating 75 to 80 patients every day who otherwise would not have access to such a facility, who would have had to actually travel long distances. The other beauty in this is, while we improved access,
This
the
70
affordability.
Sorry to interrupt. This 70 to 80, as you said, this number, give us a context in terms of, like, say, 5 years ago, how was it like,
So
how does,
otherwise these cities had no access to a radiation oncology facility. So the population from say Akola or Gondia would have to either travel 200 kilometers to go to Nagpur, or then otherwise to come to Mumbai or Pune. And these treatments, like I said, are multi-session. So these are 25 sessions, 30 sessions, 35. So imagine having to live in these cities for 1.5 months. Instead, you have access to this facility which is in your district, in your city. 99% of patients who are treated in these centers are covered by the state health scheme. So, from an affordability point of view, they don't have to pay anything. They are completely covered. Similarly, every day 15 patients are undergoing chemotherapy. So, if you ask me, this is one of a very good public private partnership where we've gone ahead, set up the infrastructure, invested in the technology. The patients are getting access to these treatments without having to pay for it, and as a result of which we are able to deliver excellent outcomes. In the next phase, we are again planning to do another 3 more districts. We are starting with Amravati next month and 2 others very shortly. So the goal will be to cover the entire state of Maharashtra. What I would also like to say is that this has had a catalytic effect. So after us, now looking at the kind of response, we've had other players who've come in and they have set up these centers. So it's about taking care to the community. It's about access, affordability, and also quality. And I always like to believe, and like ma'am also rightly stressed, your geography should not define your outcome. I think it's very, very important. I think that should be the goal, that we should be able to deliver care of a standard and of a level that we could deliver in metros in these districts and towns. I think that is what the goal should be, where all of us, private as well as public players, come together to deliver this care.
yeah, I think, geography should not define it, though. I think right now you kind of intensified in Maharashtra, which is there. Now that gives me a point to check with Dr. Bilal. At Manipal, I think you've been expanding your footprint, I think, from south to north to everywhere. Is this model possible in other geographies? What is your experience?
At the outset, a big thank you, Mr. Sharma, for holding this wonderful conclave and inviting all of us to be here. It's our pleasure. I think it's possible all across the country, maybe a little more difficult in some parts that are not connected very well and not as economically developed. But to give you an example, Manipal started in a village which was a dense forest with tigers roaming in it. That was the first private medical college in this country, set up in 1953. It literally was a forest with tigers, and the main portion of Manipal is called Tiger Circle because there were tigers roaming. From there, we have come a long way now. We have moved across the globe into areas where there are two-legged animals rather than four-legged animals. So we also believe that private-public partnership, which we started way back in the 50s, is the way to go forward, especially for tertiary and quaternary care in this country. If you see now, we have more, close to maybe 750 medical colleges, and many of them are in district headquarters, and each district has more than one medical college. And if these medical colleges adopt the government hospital in the district, then that would be a tertiary care center because it would be a win-win for the medical college and the government hospital and the citizens. For the medical college, you have a large number of patients, which is sometimes difficult to get in a private hospital for your teaching purposes. And for the government hospital, the medical college subsidizes the infrastructure of those hospitals and care is given. And our first example was the government Wenlock Hospital in Mangalore, which became part of Kasturba Medical College Teaching Center. And the government hospital at Wenlock, Mangalore, provided the best service at that time. So I do believe if we work together, not be in silos, good, high quality healthcare can be delivered across the country, not just in the metros.
Yeah, okay. Before I come to Mr. Asim, since Dr. Soumya has another meeting and some distance to cover, it is one question I do want to request you to actually look at. Is see, there was a lot mentioned about the achievements which the government has been able to do in terms of infant mortality, maternal mortality. There have been improvements in that. But if you look at again, I go back to the National Health Policy 2017, there was this element of that by 2025, we'll have health expenditure at 2.5% of GDP. We are still short of that. And talks of other things as well, including the vaccinations, adult vaccines, and all of that. What's the sense in terms of, how do we need to progress on that? Why do we still need to look at those numbers? I mean, where do you see the gaps, or your thoughts in terms of how do we take this? Because impact is when the numbers start making a difference. They've still not made a difference. So, your thoughts on how we should pursue them?
Thank you, and apologies that I have to leave for another lecture that I have to give. So the National Health Policy of 2017, so already almost 10 years old now, had said that we would achieve health expenditure of 2.5% of GDP by 2025. Obviously, that has not happened. We're still well below 2%. And both central and state governments need to actually put in, I think, more. Moreover, it needs to shift from being mostly tertiary focused and secondary care focused to more primary, because I think ultimately, if there's good primary health care, comprehensive, then you're going to reduce the incidence of complications and also make it more manageable. So I think that shift really needs to happen, and this also means that we need a workforce. I think many people have mentioned about a well-trained and skilled workforce. In fact, I was asking Dr. Raghuvanshi also, 1,500 new positions in CDSCO of scientists. Where are these scientists who have been trained in regulatory science?
And
Where
they've
are
not had anything internal, they said. These were all external, even thus far.
we new recruits,
Recruits, but even thus far, it was all external.
Exactly. So we need to start thinking about what are those areas where we are going to need more skilled people. Today, AI and digital health applications across the board. But our medical graduates are not, and definitely not the nurses, pharmacists, physiotherapists, etc. They're not getting that level of skilling. So I think an ongoing education program and upskilling program, both for the private and the public sector, is going to be important, because medicine is changing very rapidly. A lot of new therapies are coming, and while the government may, they have a good health technology assessment program that was started when I was DG ICMR, to introduce new technologies into the government health schemes. The private sector is a little bit ahead always of, offering the latest in treatments, but coming at a high cost. So I think for India, we have to look at affordability and quality in addition to safety. And there, the private sector is going to play a very big role.
Just may I just slip in just a footnote there? Since you mentioned about the whole discussion is around impact, and there's two letters of the English alphabet AI. Do you think therefore that when we talk of this impact language, do you see this increasingly playing a role, or do we have a situation where, you know, where do you see that actually making a difference?
You mean AI?
Yeah.
Well, I'm sure that all these leaders are already using AI, to look at their own hospitals, or their business and the operations and so on. Like we heard examples, of how the leadership is looking at indicators, and using AI now becomes much easier. Also, when you have a very large operation across the country, you use AI to compare what's happening and so on. But in terms of the patient or the ultimate consumer, I think that we still haven't got to the point where AI is really benefiting them. And there is a huge opportunity there, through chatbots, through the ability to remotely, like he was saying, patients are coming from very far off places. So instead of making them travel all the way for a consultation, can we do it much more systematically, through telemedicine and through also AI now being able to give. But again, we have to be a little careful. When it comes to AI, there are ethical and legal and regulatory issues. So this is where I think we need to develop the products, test them, and the CDSCO will have to have a way of regulating, because it can be unsafe also. I know instances where mental health bots have encouraged suicide behavior. So we've got to be quite careful. But at the same time, I think the opportunities to reach out to people with AI now are tremendous. And there's a lot of innovation that's possible there. Thank you very
Thanks.
much.
Thanks so
And
much. I can
I'll excuse
understand your-
myself.
Yes,
if you
I
don't
know
mind. Yeah.
you. But thank you for at least staying. Yeah. Thank you. Mr. Malhotra, I think we should therefore, I think, going by what Dr. Soumya mentioned also just now, from a digital service provider's perspective, I think if you can, when there's so much of discussion around the influencing of the clinical practice, given what you've heard thus far, over the next 2-3 years, what do you think, how this can make a difference, the digital interventions over the next 2-3 years in terms of clinical practice, in terms of output, what some of the things which Dr. Soumya mentioned?
Yeah. So firstly, thank you for having me here and for a wonderful summit. I think I'm glad that you asked 2 or 3 years and not 5 or 10 years, because I think the pace at which technology is evolving, if anyone claims to know what's going to happen in 10 years, then
I said 2 or 3 years because at least I don't want a bot to replace me.
Yeah, I think I'll allude to a few things that were discussed today, and some real world applications of how, let's say, technologies like AI, etc., are being used by organizations like BrainLab. So, coincidentally, just exactly a week ago, we were in this room. BrainLab organized a radiation therapy user meet, the first of its kind in India in the last 10 years or so. It was chaired, and the keynote address was given by Professor Dr. G.K. Rath, whom many of you may know, of course, is a legend in the radiation oncology space, the architect of NCI, and has so many other accolades to his name. And one of the examples of real world case usage of AI was presented amongst the many institutes that have that today, which is around really treatment planning, right? So when we talked about radiation oncology, for example, the execution on the radiation oncology, the treatment, can only be as good as the planning that you do, right? So how precise that planning is, what level of metadata is that planning actually based on, those AI algorithms based on, I think that determines a lot of the outcomes. So the case presentation that was done was of a young lady. So someone who, if is affected by cancer and has an impact to their quality of life, at a very young age, that impacts the rest of their life, it impacts their family, the community, etc. And because of the level of precision that the AI planning tool was able to do, they were able to treat multiple brain metastases. So that lady had 16 metastases, 16 lesions in her brain. The brain is one of the most complex parts of the anatomy to treat, right? And it was only the quality of planning which they were able to do.
We provided that to them on a server. So it didn't matter if the medical physicist who was doing the planning was sitting at home or was on the road, or, and they were concurrent licenses. So multiple people could collaborate on that treatment planning. They were able to give much more heavy dose of radiation, knowing that the plan was a lot more accurate, and they were able to treat those 16 lesions. So this is a very, very small example of how a very big topic like AI can have a very practical and real world application. So I think that was very heartening to see.
Okay.
The second area that I would probably want to talk about is mixed reality. So I think the way that treatment is happening today, whether it's both planning as well as execution, let's say for surgery, for example. So when I say mixed reality, I refer to a combination of augmented reality and virtual reality. And again, I can share an example. So one of the new sites for Aster Hospitals in Bangalore, in Whitefield, we worked with them to set up a VR room. This was about 8 months ago, and was inaugurated by Mr. Narayan Murthy, who spent almost an hour in that VR room understanding this technology. And the way that we use that technology, which coincidentally is outside at our booth, so if anyone is interested, you can actually go and see it, is to load the actual patient data onto these VR glasses, right? And you're actually able to see the entire surgical plan through that in 3 dimension, right? For that particular patient. So what this does, the two ways that at least this hospital is using this technology really well. So one is patient counseling, obviously. So a lot of patients who come for treatment, there is very high levels of anxiety, especially, for example, if you have pediatric cases, right, where the parents are extremely worried that the child is going to go under the knife. So how do you reduce that anxiety? How do you actually show them what that surgical procedure is going to look like, where the tumor is going to be excised from, etc. The second, I think, is on education. So the hospital is actually able to use this technology to train a lot of their younger physicians who are coming up the ranks, and they're able to cut. So by their estimate, in just 6 months, they've been able to cut 3 years of training time for all of their residents just because of this technology. So I think there's a lot of power there behind that technology.
Yeah, thanks so much. Dr. Balal, at least in your area, I mean, the minister also talked of, kidney care. I mean, nephrology, you've looked at in great detail as well. What is from an impact perspective and this whole discussion around on technology and how that will make a difference, what is the sense you get in terms of how you seeing the scene on the ground change, and what's your immediate priority?
Thank you for this question. This is very close to my heart. Nephrology, or the treatment of kidney diseases, has evolved considerably in India in the last few decades. When I first came back from the US, believe it or not, our entire country of 1.2 billion or so at that time had 800 nephrologists. And in the US, there were 1,200 Indian nephrologists of Indian origin. So we had more nephrologists from India in the US for one third of the population as compared to the nephrologists we had in India. And we were proud that we were more than one. We were 1 in a million at that time. But things have changed. Many new training centers have come, and I must thank the government for actually promoting this. Dialysis, which is one of the treatments for late stages of kidney failure, was not accessible to most people. And believe it or not, about 97 or 98% of the people with severe kidney disease unfortunately had a miserable death because it was not accessible. The treatment was not accessible and, at a large extent, not affordable. However, now every taluka has dialysis units, and most of them are provided by the government and by charity organizations like Santosh's, which I'm sure does a lot of subsidized dialysis. So we certainly have come a long way, and the technology of dialysis also has improved. So has the technology and the means of doing kidney transplantations have improved. We now do robotic kidney transplants. We have a lot of new medications which have significantly increased the survival of patients with kidney transplant. Gone are the days when a mother would say, when we would tell the mother, your child has kidney failure, and she would get onto the floor and start rolling around saying, that's the end of my child's life. Now they can have almost a normal life. 20 to 30 years survival after a transplant is well known, and dialysis is available in every nook and corner of the country.
Very quick point, actually. So, from an impact perspective, I mean, what would be your immediate concern? I mean, what is it that you are currently focused on? If there's one thing you would
Yeah.
want to include or add, or what?
What I would really like to say is we talked a lot about out of pocket expenditure. The Honorable Minister spoke about it, and so did many others. I think the only way you can reduce out of pocket expenditure is make sure that the patient doesn't come to the hospital. So, our focus should really be prevention. Kidney disease, diabetes, hypertension, obesity, cancer, these are all lifestyle diseases. And we can potentially prevent them and reduce the cost of healthcare significantly. And that's what our focus should be.
Dr. Santosh, on prevention, which is saying, I mean, of course, you have been looking at this aspect as well. Some thoughts in terms of what you would think needs to be done when it's not being done. I mean, it's top of your mind agenda right now. Say over the next 1 year, what is it that you think should be done?
Right. So one of the things, you asked Dr. Soumya in terms of the GDP spend, with a country of 1.4 billion people, no amount of spending is ever going to be enough if the focus is going to be on tertiary care. So it's all going to be about prevention, screening, and early detection. I think these are the 2-3 elements which are going to be very, very critical in this whole thing. And along with that are, of course, some of the government initiatives that are coming through in terms of what the Honorable Minister mentioned this morning: eat right, stay fit, exercise. So, as part of our ethos, preventive health checkups, health awareness talks are those are two very big areas that we as an institution focus on. So we work with large community groups. What we've realized is that community groups, they identify very well with each other. So if there is an influential community leader who addresses them along with our doctors, that's something. So practically every month we have 2 such talks where we have around 500 to 600 people of a particular community coming in, and we have our endocrinologist, our cardiologist, our preventive health physician talking to them, giving them a sense of what it takes to prevent, what are the things that you need to watch out for, how do we screen, how do we detect early. So it's going to be a continuous education, a continuous awareness, look for early warning signs. These are the things that we as an institution try to focus. Here you have to work directly with the community, and of course the government is doing a lot in terms of health and sanitation and awareness. So all of this collectively will have to get to a level where we don't talk of increasing spending. That's not something that's going to work in the long run. So long term, I think prevention is going to be the most critical element, where all stakeholders will have to get together, right from government, public, private, community, and an individual himself.
In the interest of time, actually, I want to look in terms of just last bit about future ready organizations. In terms of when we want to look in terms of building future ready organizations, uh, if Mr. Surendra, you can mention in terms of, see, in your space in diagnostics, there is also very briefly, if you could touch upon this whole thing on genomics, which also is being increasingly discussed. So any thoughts on that, and your immediate priority when trying to build a future ready diagnostic uh, operation?
Yeah, you're right. I think genomics is the next frontier of diagnostics for sure. And for your early detection of predictive risk, and and then treatment, and going it actually the precise precision way, getting things into individualized treatment and diagnosis can only happen through genomics. So today in itself, in India, genomics is almost about 500 600 million USD kind of a market today. So we've come a long way, but I think the future of genomics will depend upon how much we do invest in the infrastructure, genomics infrastructure, for the next investment in the next generation sequencing and bioinformatics, and also skilled manpower once again. So the future will remain on this, and also making sure how do we train the clinicians and how do you collaborate with the clinicians to make genomics being used as a day-to-day decision-making process, So definitely genomics is the future. And I think as an organization, all of us in the diagnostic space, definitely getting prepared in terms of infrastructure, in terms of people, in terms of all the bioinformatics, etc., etc. So this is a long journey, but I think we have done quite a bit of travel quite a bit of a distance, and committed to make this big in the days to come.
Okay. Mr. Azim, I saw you nodding when you were discussing about technology. I think that probably is something which excites you about this whole space. Uh, when we, before I come to Mr. Vipul Jain, when we talk of this future ready organizations, in your view, there are various ways in which they could look in terms of where to prioritize, what to, because funds again are have limits, isn't it? So in your view, what's your understanding in terms of when let's say these healthcare professionals are or healthcare providers are trying to look in terms of prioritizing their expenditures here, what kind of technologies you see in the next couple of years where you think investments will increasingly flow into?
It's funny we are talking about 10 years technology and we can't get the mic to work, but yes. um,
Try that with telephones.
I think if I was to put my shoes in some of the in the shoes of some of the gentlemen here, and when you're making an investment today in, let's say, capital equipment or in technology, you're spending crores of rupees, sticking your neck out on taking a bet on that technology. And the question you might be asking yourself is, I'm buying this today, is it still going to be relevant in 2032 or 2035? Right, that same thing is still going to be lying in my OR or my OT. So I think one of the reflections, and at least the ethos that we come from at BrainLab, is that the platform should be upgradable. So, and that can only be driven through software. So there's only that much that you can bake into the hardware. So whether you're looking at a surgical navigation system, whether you're looking at a robotic system, how upgradable is that system through software? So I think that's the first one. The second one is, how open is that system? So as we build technology, there is a danger of technology being built in silos, whether that's AI or it's robotics or other things. So the other thing that I would look at in terms of platform acquisition is how open those platforms are. So can I buy a robot from one company, and can I use implants of any other company, including Indian companies, that I want to? Because that impacts my total cost of ownership. It impacts the fact that maybe today the surgeon who's using that robot is very fond of one particular implant, but in 4 years I have a new surgical team and they hate that implant. They don't like it because they've not trained on it or they're not comfortable with it. So am I an upgradable and an open platform that's vendor agnostic? I think these are probably two strong considerations for future proofing whatever you're investing in
Oh,
today.
okay, yeah, interesting actually. Um, Mr. Jain, I'll let you have the last word on this, but uh, one area which we have not touched upon when we talk of cure to impact is, do you think, I mean, we had some discussions earlier as well over the period. Uh, what role you think insurance can play in ensuring that the impact is genuine? Really, is there any role that insurance can?
So, good part is, and this is a prediction for a few years down the line. Let me not go 5 or 10, but today 40-50% of people pay out of pocket. It's a matter of time. My guess, about 5 to 7 years, that 95% of the healthcare provided will be payer driven, which is either insurance will pay or the government will pay. Broad estimates say that 65% of the population health coverage will be done by the government and 35% will be done by insurance at a country level. At metros and all, the insurance coverage will be much higher. The payer can fundamentally change the way healthcare is provided. Today, both from a quality angle and an affordability angle, if a consolidated player which is taking care of crores and crores of insured population as its customer base and negotiating with a hospital or with any provider, be it a pharmaceutical or a diagnostic entity, that leverage and that power can actually fundamentally redefine the way quality care is delivered. And I do believe, instead of episodic incentive mechanism, which is I come for a, let's say, a knee replacement surgery and I get paid, let's say, 3 lakh rupees by the insurance company, people don't come to get a knee replacement. People come to solve the knee pain. They want to get back to their life. They want to play with their kids. They want to walk and run, right? So it is actually about the outcome to the patient. And if you pay for the outcomes, if you pay for the quality of the outcome, the return to life, not for the forced break in their life, which is the episode. I think that is the role which insurance can play.
Very interesting point to actually conclude on. But when you say that outcome based insurance payment, so it's not based on number of consumables used that the payment is made, but based on the net outcome for the patient. But do you think insurance companies we can get to do that? What's your experience? Do you think it's possible? Anyone on this panel?
So interestingly, this is how, at least in US and in UK, things have evolved and are evolving. For certain type of surgery, certain type of community health statistics, that is how incentive mechanisms have been put in place. So, for example, if you come to a hospital for a heart procedure or a surgery, and if this patient dies within 30 days, actually the bare minimum we can do is just incentivize this, right? Which is, you will not get paid, you will be penalized. Right? So there are mechanisms we can learn from the West. These are systems which are better evolved. But yeah, would be good to hear from others.
I think it's quite prevalent in the Western world, especially the US, where you actually pay to make sure that the patient is kept out of the hospital. And also, there's a incentivization to get unnecessary specialists involved in the care. So, the lump sum is paid to a doctor or a doctor's group for the care of the community. And the lesser they spend, more the money they save. But there are also safeguards to make sure that they do the right things. Just because you have to spend less, if someone needs a heart surgery, you don't keep them in the medicine OPD. So it has to be a very mature, robust system. It will take some time, but that's where we should go. It should be outcome based insurance, and rather than insurance companies being gatekeepers as to who will come, what procedure they'll get, what is the lowest cost we can charge them.
Oh, great. I'm happy the provocation was for an agreement. So great. So thank you so much. We could continue like this, but then the dashboard keeps screaming at me. So thank you so much. Thanks a lot for improving our understanding of what we should be asking you next time. So thank you so much again.